It is Magic Monday here on the Overrun. I'm Ed Bowder.
I'm Dan Schwester.
And today we are going to be talking about ketamine versus etomidate. This study it was kind of a multi-center study. It came out of a bunch of different places. Specifically, we're looking at authors out of Italy and Canada. So we'll pull this up. We'll start going over this. What I thought was interesting about this study is I'm not super convinced that we spend enough time really talking about the right induction agent for RSI. I tend to think we talk about it a lot, I guess, but I don't know that we've really elucidated which one is the proper drug, whether it's ketamine or etomidate.
I don't know. I think we bounce this around so much, but there's nothing substantive about it. A lot of it is, I like this because I like it.
Yeah.
There's a lot of arguments on both sides. I'm surprised that we haven't definitively studied this, but I don't know.
I think it's hard to definitively study anything really, but I think we've spent so much time worrying about like what are the right or wrong drugs to use that sometimes we sort of get lost in the weeds, right? So
Sure.
this was looking at, and again, this talks about, tracheal intubation is a high risk intervention. It's on critically ill patients. So this is a meta-analysis, which is another thing that I think is important here. So they looked at Medline, Embase, Cochrane. So with a meta-analysis, what's going to happen is the actual researchers are going to go in and they're going to cull or pull the data from available places, right? So they're going to look at all the data. It's data looking at data. So when they went through this, we have 7 randomized trials that totaled 2,978 patients. And they compared etomidate and ketamine, and they wanted to see what happened. So here we see the probability that ketamine reduced mortality was 83%, right here, versus 27%. They show the relative risk here, which is confirmed by a subgroup analysis excluding studies with a high risk of bias. No significant difference was noted in secondary outcomes. So the conclusion to this, all of the included studies evaluated ketamine versus etomidate among critically ill patients or critically ill adults requiring tracheal intubation. This analysis showed a moderate probability that induction with ketamine is associated with a reduced risk in mortality. So here is their graphical abstract here. We can see that the probability of survivor benefit is 83.2%. So let's talk about these drugs here, Danny. Now we've been on record sort of standing ketamine at this operation. I certainly prefer ketamine over etomidate, and one of the concerns for etomidate is adrenal insufficiency, and there's a whole bunch of other long-term concerns that I'm not convinced we need to worry about in the pre-hospital arena.
No, etomidate or ketamine, I think pretty much so far, I think it's a 6 of 1/2 dozen the other thing. You get certain advantages if you go deeper into studying these meds. You get some advantages with ketamine, you get some with etomidate, but I don't know that we really know one over the other, and I don't know that we've studied it.
So the outcome of this study, the primary outcome was all-cause mortality, right? And then we looked at sequential organ failure assessment, ventilator-free days, vasopressor-free days, and looking at MAP after induction here. So they go through this analysis. And again, this is their results here. They looked at 7 different RCTs with exclusion. So we got down to these 8 studies here.
Right.
The dose of ketamine in this study group was 1 to 2 milligrams per kilogram, except for one which used 0.5 milligrams per kilogram, and they used 0.5 of propofol. That is a combination we know it's known as ketofol, and ketofol has been used in hospital a lot. Hasn't really been used pre-hospitally as much. But the reason that the dosage of ketamine is important is this is your pretty standard dose of ketamine. Most projects I've worked at have been between 1 and 2 milligrams. Certainly there's some suggestions that you can use higher doses if you have to. But again, this wasn't looking at things that were outside of the standard treatment for patients. So here we're looking at these actual studies, what they looked at, right? Etomidate was the comparator in all of these different studies. This is the data that they found. So this is where we get into kind of the meat of the study and the interesting part here, right? Mortality, the longest follow-up available, 83% benefit, right? Randomized control trials, 68% benefit, exclusion, right? So we got these vasopressor-free days, 67%, ventilator-free days, 55%. I don't know that those are independently associated with ketamine versus etomidate.
Well, the investigators seem to think so.
I can understand
I mean,
the
defend
reasoning,
that.
but I mean,
Why?
well, because it's the same thing as any study, right? I gave a patient ketamine instead of etomidate, and then a brick fell on them, and now they're dead. I
Uh,
don't know. I understand, and I'm not taking away from the end of the study. I'm not taking away from the actual meta analyses. I I don't know. I'm hesitant seeing one meta analysis on this to really make a decision, but what they have found is really the important thing here, right? So we know that ketamine and etomidate are the suggested agents for RSI because of their modest cardiovascular effects. So again, we know that ketamine can temporize blood pressure unless you give it too quickly, which then ketamine can precipitously drop blood pressure. And something that is not mentioned again in this study is the method in which the ketamine was delivered. Obviously, it was all IV, but was it rapid push? How are they being monitored? And again, here, this is the biggest thing, right? Etomidate was the only comparator. Its common adverse effect was adrenal insufficiency that may have affected a mortality result. So looking through all these things, and it talks about strengths limitations, but this is really the big thing here. Again, we always look for further research is required to determine the potential benefit. But what it talked about, we found that a moderate probability that induction with ketamine compared to etomidate was associated with a reduced risk in mortality. So getting into this, Danny, what do we think about the actual findings here?
I don't know that they're really conclusive. I'm not convinced. I know they did it seems like they did their diligence. They did a good study. However, remember when we're looking at a meta-analysis, you have to remember it's a study of studies. It's not
Right.
actually studying effects. And if so we have to go back and look at all of those studies to see how they were done and what the benefits were and how it worked out. There could be flaws, it could be bad studies, and with meta-analyses, garbage in, garbage out. If you don't have good data, you're not going to get good results. I think it's interesting that they did show a potential benefit for sick patients with ketamine. I don't know that it's enough to throw away etomidate yet.
No, and I think that's right. If you're being pragmatic in your system, you want to have some sort of redundancies, right? So if I'm using ketamine primarily in my shop, and I've got someone who, for whatever reason, can't take ketamine, right? We know that the increased intracranial pressure thing is a fallacy, but if I have a medical director who is being more conservative, or you know what, if I have a vial of ketamine that I dropped at the beginning of the shift and broke, you want to have something that is a decent backup. And here, I think etomidate. Now, what would change for me looking at this is I would think that maybe this would push ketamine more toward my principal agent over etomidate.
Yeah, that would fit.
Right, where so I'm planning on using ketamine for this induction or for this intubation. If that doesn't work, then I have etomidate available to me. I think that's kind of the finding that we're seeing here is.
I mean, I'll be honest. I still, if I have somebody with a really sky high pressure, like an intracranial hemorrhage or something like that,
Mm,
I lean towards etomidate because I just think, yes, ketamine might raise blood pressure, it might keep it the same. I don't want to see a positive change in blood pressure with that kind of patient.
sure.
I think etomidate is pretty much cardiac neutral. And remember, when we have people that are dumping catecholamines into their system to stay alive, when we take away that stimulus, you're going to see a drop in blood pressure, whether you give ketamine, whether you give etomidate. But I think the bottom line for me is, yes, this showed that there was a benefit potentially. I think we need to look at this more, but knowing your meds and knowing what you want to do for the patient is really critically important.
And I think that's right too. I think it arguably is one of the most important things here. The one variable that, and I should have mentioned, this was published in Critical Care earlier this year. The one thing that I think is something that needs to be mentioned is, again, these are critically ill patients, right? And we know that they're being induced because they can't control their airway anymore. So I think another question has to be, in this population, how many of them were moribund in the first place? where
Yeah.
you have, because I don't know what the number is, but I'm certain that there's a percentage of people in this cross section in this study, or involved in these studies in the study, that you have someone who is so sick with sepsis, that the only option you have is you have to intubate them because they're going to be on 7 pressors, or you have someone who is a critically ill trauma patient. Were they involved in this paperwork, or in the findings? Were they part of the sample? So it's difficult to really get a good read, I think, because while it's sexy to look at the critically ill patients, we also have to wonder how many of those patients would have expired regardless of our interventions, right? And you see, like, like if there's a trial on something like Reboa, or a trial on something like balloon pumps, or caths or VADs, we don't question the mortality because we know that those patients are critically sick. Here, it feels like, these patients may have survived with ketamine.
Yeah.
But I'm
It's
while
hard to
again,
say.
I am pro ketamine frontline and backline and RSI.
Mhm.
I'm not convinced that this study really answers those questions for us. But I do
No, I
think,
agree.
right, and I do think that it adds to the conversation, though, where you can
Oh yeah.
have a more quantifiable conversation with people saying, like, no, look, I prefer ketamine because it's generally cardiac neutral and it's associated with higher outcomes. Now, there's also technique factors that we have to add into that too, right? Are you pro ketamine because you give ketamine appropriately, or are you pro ketamine because you've lucked out with the patients that you've had?
Yeah, this comes down to, in the end, I think, just like everything, um, one consistent thing that we found in looking at all of these studies and all the things we read is sick people do poorly, right? Really
Right.
sick people do really poorly. Um, that's a common, how that works is up to debate, but let's be honest. Um, I don't know that this changes my practice.
Yeah, I think it's a bit much to say that it's practice changing, at this point. But again, this is something. So this just came out a couple months ago, and it's certainly something that has have been contributing to the literature. So it's a conversation that we're going to be
Yeah,
having
I
more and
will
more.
I will say one thing is that it's good, and I'm glad they did it, and we need more of this stuff, and we need more studies. We need to continue building a base of evidence so that we can be evidence-based.
Right. What I want to see is I want to see. All right. So it's perfect world, right? So what I want to see, I guess,
Is
is
it?
is it though? Um, in a perfect world scenario, I think I'd like to see whether, and I don't know how we would do it. So certainly this is going to have to go out to some of our more researchy people.
Mm.
I'd like to see a closed label trial in RSI using ketamine and atomidate as the closed labels. I'd want to see a study that you, and I don't care what your paralytic is. Like, sure, you're using rock, sucks. I don't really care. But I'd want to see, we used ketamine, we used atomidate, we randomized how they were given, and now we're tracking these outcomes. And because I'm not convinced that if you send someone up into the ICU after you gave them ketamine for induction, that they're going to note that and be like, oh, well, this is the ketamine guy.
Yeah.
But I do think that would be an interesting way to kind of look at how RSI and resuscitation are being done, especially since so people are still kind of, they're a little bit dodgy about ketamine still, it feels like. I'm basing that off nothing. That's anecdote. I don't have any data to back that up. But it still feels like people kind of get, again, anecdotally, I've still had people come up to me and be like, I can't believe you guys even carry ketamine.
Yeah. Yeah,
And
I
that's
still get that.
right. And so I wonder if almost that's something we have to get rid of first, where we teach people more about a drug like ketamine, and make it a more effective drug, where we talk about how the pharmacodynamics actually work, how if you're worried about reducing a patient's blood pressure with ketamine, if you just give it appropriately, it probably won't drop their blood pressure. um, what patient populations are going to benefit from ketamine versus atomidate, where again, if you've got someone who is catecholamine depleted because of whatever reason, whatever infectious process they have, or if they're a trauma patient, those kind of things, maybe
Yeah,
you're better off giving one drug over the other, right? If I've got
it's
someone,
possible.
yeah. And in the field, we're certainly never going to know if a patient has adrenal insufficiency. We're just not. It's
No.
not, I mean, short of going to a nursing
That's
home.
a down the road thing, and
Yeah,
again, we have a fair amount of evidence, not an overwhelming amount, but a fair amount that shows that only one dose of etomidate doesn't really do that. It has the
right.
potential to do it with repeated doses, but so far what we're finding, not so much.
Well, and the other thing to consider too is that everything has an LD50, right? I mean, water has an LD50. So it's not so much the agent necessarily as it is the administrator sometimes, I think. And, we certainly want to find a place where we can facilitate intubating either in an easier fashion for the provider or in a way that's going to be more beneficial to the patient. And again, I've been team ketamine since we started getting it back out on the
Me
trucks.
too.
Um, and I think it's interesting that people will like ride or die for it too. Uh, but that said, I think right now, I feel a little bit validated looking at this study because it's like, yeah, you're damn right, ketamine is the first line agent. But I do think it has to give us some pause for using ketamine or etomidate, depending on the circumstance.
I think what it comes down to in the end is what we're seeing is that it comes down to the clinician. It comes down
Sure.
to your training, your experience, your knowledge of these medications to apply them or to request them in the proper scenario so that we can do the best things for our patients.
Right. And it's something we've talked about with other people previously on the show too, where, your system is your system. So
Mhm.
if you want to improve your system, it might be that you work in a population that is exclusively catecholamine depleted. So you have to change your actual treatment based on that. Or if you're working in a super conservative city system, you might not even carry ketamine because you might have, it might be a risk aversion or a loss aversion thing. So there's plenty of reasons where you might have to decide between one drug and the other. I'm not sure if cost is actually really a factor that we need to consider here, but you have to know what your actual population is. So if you're a provider in an area that has RSI and is working with these drugs, you need to be able to know, all right, if I see this type of patient presentation, I'm going to use ketamine. If
Yeah.
I see this patient population, I'm going to use etomidate. And
Mhm.
that's where you get little benefits. Like, if you're going to a job or a call and you are in the truck getting ready to see this patient, that's where you have to have those conversations with your partner, right? Where like, okay, so we know that this is a head trauma because it came across the head trauma. The note says that, the patient took a header off of a 20-foot ladder. Okay. Is this someone that we're going to worry about increasing their intracranial pressure? Well, obviously, yes. Right. So that's where you have that more kind of in-depth conversation where it's, I don't know that ketamine is the right induction agent for this patient. We might be better off using etomidate. And even in that setting there, you can get into your paralytics and your post intubation medication. And I think having that conversation on the way to the job, is that something that you're still doing on the way to a job? Do you still kind of like pre-brief going
Yeah,
into a job?
absolutely. We'll play the what if game. Be like, oh
Yeah,
well, if we get this, how are we going to go with this, or what do you want to do? I mean, we do it in the back of the truck too when we're deciding how we're going to
sure.
plan for the patient. Well, what do you think? What are we thinking is the problem here? How do we apply the solution to the problem? It's it's what we're supposed to do.
Right. I think that's another thing too. We've I think as an industry, we've sort of focused on a lot of buzzwords, and
Mhm.
we've sort of gotten a little bit away of what we're supposed to do. Where again, we can take us back to this study. So what you're supposed to do in the setting of a critically ill patient who needs intubation is you're supposed to be able to adequately sedate them, adequately paralyze them, and make sure that they're able to get the intubation and work with that machinery and that tube better than they would have otherwise. That's where you
Without
have
hypoxia,
without
without
hypoxia.
hypotension, and
Right.
without all the badness happening because we're good at what we do and we do it well.
Yeah. And we generally just want, and anytime you see a bad thing, we want to avoid bad things
Or mitigate them.
or mitigate them. Right. So, and this is another setting where if you have the patient and you have an academic conversation of you're going to use ketamine versus etomidate, you also have to be ready to resuscitate your patients, especially in the RSI setting. And again, conversations we've had millions of times, but we thought it was kind of fun seeing that there was an actual meta-analysis between ketamine and etomidate. Please bring this to all of your friends in EMS and talk about it, ask them if they've heard about it, because the paper is very, very new. We're also interested in your comments. Be sure that you click subscribe, which is going to be right there, and go ahead and follow us on all the different social medias. For this Magic Monday Journal Club, I'm Ed Bowder.
Yeah, I'm Dan Schwester.
And we'll talk to you all next week. Enjoy
Take
learning.
care, everybody.
We'll talk to you then.